I'm Dr. Seemal Desai. I am a board-certified dermatologist in private and academic practice in Dallas, Texas. I'm a pigmentary disease specialist with a special interest and focus in my practice on vitiligo. And I'm here with my friend and colleague, a fellow vitiligo expert extraordinaire, Dr. John Harris, who's professor and chair of dermatology at the University of Massachusetts in Massachusetts and leads the Vitiligo Treatment and Research Center. John, it's good to be here with you.
Yeah, glad to be here. This is a great place to be.
This is great to talk about vitiligo, our
Absolutely.
areas of passion and interest. So one of the things that I think you and I always get asked, and we've shared a lot of podium time together, a lot of research time together, which has been a real privilege, but we always get asked about how do you approach that treatment naive patient who walks in, who has new onset vitiligo, and where do you go with deciding when to incorporate what type of topicals, when do you incorporate orals, when do you incorporate phototherapy? And I think both you and I sort of base it on a algorithmic kind of approach, but wouldn't you agree that vitiligo is really a polypharmacy, polytherapeutic kind of disease?
Yeah, I like to have a toolkit, and I like to present the toolkit to the patient. We've talked many times about giving the patient options and allowing them to decide, but the toolkit's growing, and we have a lot of options now. And it depends on the presentation. So certainly one of the most important things to me is whether the patient is active or stable.
Right.
If they're active, then it takes us down a little bit of a different path to stabilize it first and then kind of move on. If they're stable, it gives us some time to ramp things up and try things and see. Whether it's a kid who's going to college and isn't going to have access to phototherapy, or someone who lives, for me, in Maine, has no access to that themselves. So a lot of things kind of go into it, but having that toolkit is really key.
I totally agree. And so the other question, speaking of active and unstable, I'm really glad you said that, because John and I are big advocates for looking at disease activity on that first visit. And there is such a thing, wouldn't you agree, as vitiligo emergencies.
Right.
We see patients with confetti disease, trichrome morphology, rapidly expanding lesions. Those patients need help. This is not a cosmetic condition, contrary to what, unfortunately, many insurance companies still believe.
Right.
This is a disease that has a lot of autoimmune phenomena. So going back to active unstable, I a lot of times get referrals for vitiligo patients that come to me and say, oh, my dermatologist said my disease is unstoppable, so a topical is not going to work for me. And I sort of always say, a topical may not be all that will work for you, but that just because you're unstable doesn't mean you wouldn't use a topical JAK. Do you agree?
Right. I think everybody gets topical coming out of my clinic.
Totally agree.
And then the question is, how many other things do we layer on top?
Stack on top, yeah. When you think about topicals, what we used to be on podium, I remember 5 or 6 years ago at meetings you and I were together talking about calcineurin inhibitors and topical steroids and weekend dosing and pulsing and 2 weeks on, 2 weeks off. Now we really rely on topical JAK inhibitors, and having topical ruxolitinib FDA approved just a couple of years ago has been game changing.
Right. Yeah, the only FDA approved treatment we have to repigment vitiligo.
Right.
So before that, the only FDA approved treatment we had was to depigment vitiligo.
Right.
It's not a great solution.
No.
But now we can repigment vitiligo, and I agree, topical ruxolitinib has really been a game changer. And not only, they haven't been tested head to head with other topicals, so we can't yet say that they have higher efficacy. Seems like people are repigmenting faster and more consistently. But even beyond that, what was very challenging before was to try to educate a patient how to do that pulse and back and forth.
Yes,
so use a steroid, but then stop the steroid and use the calcineurin inhibitor. But on the face, don't use the steroid, only use the calcineurin inhibitor, and don't alternate. And I would have patients coming in who are using clobetasol in the face,
and
not
they mixed it
taking
up.
a break.
That's right.
They're just confused.
They're confused.
And sometimes, we're going through an interpreter and trying to explain all that, and people are just really confused. And they're getting the diagnosis for the first time, so they're not hearing everything anyway, so we try to write it down. And I think that very complicated scheme stopped patients from trying. They would come back and say, I didn't really do anything. I don't know what I'm doing.
Right. And I love that you have always been such a big champion of patient compliance. I've heard you talk about that for years for vitiligo patients, that it's not a sprint, it's a marathon.
Right.
And I think we have to tell our patients that this disease takes a long time to repigment, but we can get it better.
Yeah, a lot of patients hear that we can't, right? They go to a dermatologist says there's nothing really we can do. And I've talked to plenty of people who tried topicals and they tried it for 2 weeks and they went back and said, oh, it didn't work. And the dermatologist is like, well, I got nothing else then. It is, setting expectations is critical. So when you tell your patient, look, great news, if you've got large, patches of vitiligo, but the hair growing inside the vitiligo is still dark or still its normal color, I can almost guarantee they're going to repigment, as long as they stay the course. So that's the first thing we say. Great news, you're going to repigment.
You're going to get better, yeah.
The key is you've got to be consistent. You've got to use the medicines. We're going to check in. Sometimes I know a lot of our friends are bringing people back sooner, not because they expect to actually see anything, but to just cheer them on.
Exactly.
2 or 3 months later, they want to bring them back in because they've been slogging through this and they're not seeing much. And they have to say, that's okay, we don't expect to see much, keep going.
Yeah, I think you were referring a lot, I know you've heard me say that a lot, and I do those 3 to 4 month check-in follow-ups, and it's mainly to take pictures, to use the Woods lamp, let people take their own images, even if there's partial improvement, to be really enthusiastic about that few perifollicular dots that come in.
Right.
So talking about the topical JAKs, I had a patient who came in just this week, was doing really well, had repigmented using topical ruxolitinib. Beautiful result on the forehead, on the neck, and the back. And we sort of talked about the fact that she'd kind of reached a point where she was really happy with it. And then the question came up, well, now what do I do? I'm happy with where I am. I don't really need a refill right now. I've got enough. So Dr. Desai, what should I do? Should I just stop? Should I keep going twice a day? And per the FDA package insert on this approved therapy, you can go twice a day. You continue using it for up to 24 weeks. You can then reevaluate. Now we have long-term data that says push, 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 keep going, keep going, keep going. So again, going back to the topical, here's another question for you. And this is something that I do, but I'd love to know how you approach it because it may be different. Patient comes in, every patient needs a topical like we talked about. Every patient does get a topical. But I don't have enough in a 60-gram tube of ruxolitinib for them to use that all over their body.
Right.
So what I tend to sometimes do, and I'd be curious how you handle it, is use the ruxolitinib on the kind of tough areas where I kind of need the power of that JAK inhibitor. I always use it on the face, head, and neck because I know it works beautifully there. But then I'll say, if you've got elbow lesions and knee lesions and hand lesions and face and neck, use your topical JAK there. And then for your thighs and your buttock and your abdomen and your back, let's go and use the calcineurin inhibitor alternating with the steroid. So in essence, I get this question a lot at a recent meeting. Someone said, so you'll give people 3 topicals? And the answer is sometimes I do, where I'll give them a topical JAK and I'll say, save this for the tough areas where you need the power, and then use the other stuff where you've got a lot of hair-bearing areas that I think they'll respond. So my question, I guess, for you is, do you do similarly or am I an anomaly?
No, we've done that. Again, conversation with the patient. These are the tools that we have. These tools cost a certain amount. You can only get so much. The package says 10% body surface area, so don't treat more than that.
Right.
Because of the long-term treatment, people are using it for 2-3 years, and so that's kind of why that BSA was chosen.
Right.
And usually what I tell them is, pick the most important areas to you. Use the topical JAK on those areas first, and then up to 10%. And then sometimes we will give them the other creams. I worry a little bit that with the 3, then they get confused again.
It is. It happens.
I have a very low bar for starting narrowband UVB. So if they've got more than 10%, I think they need that too.
So glad you talked about phototherapy because I use a ton of phototherapy. I think phototherapy is an incredible agent not only to repigment, but I also, as you agree, I know, is a great stabilizing agent. So someone comes in with unstable disease, not only are they getting oral steroids to calm it down and a topical JAK, they're getting a light box recommendation or excimer laser at minimum. But a lot of our colleagues still think that in order for the topical JAK to work, you have to use it with UV light. And I actually quote your paper a lot on this.
I did publish a paper on that.
You did. Right. You published a paper in the Blue Journal. I have it in my lecture. Yeah. In fact, I recently had it in one of my talks, which said concomitant UVB can help the JAK, but it's not mutually exclusive.
Right. Yeah, and we published another with Brett King actually published.
Yes.
There was just a case series that said with oral Xeljanz, light enhanced the treatment. And actually the conclusion of the paper was that it was necessary. But light is not narrowband UVB. So he did have some patients who used oral JAK inhibitor and prevented their skin from getting light by using strong sunscreens and clothing and staying out of the sun.
Yeah.
And that didn't work as well as when patients were using it and allowed their skin to get light. So in some cases that was narrowband UVB treatment. In other cases it was a soccer coach that just was outside a lot.
Right.
And so there's a difference between saying, well, light might be necessary for JAK inhibitors to work, and saying everybody needs UVB to combine with it, right? That is not true.
That is not true.
Because
right.
the clinic, phase 2 and phase 3 clinical trials did not combine with light.
Exactly.
And that's the data we're quoting and showing everyone.
Yep.
Clearly works without it.
Right.
But what might be necessary is incidental light. You might need to get a little bit of sunlight here and there. We also don't tell patients to use strong sunscreens when they're using it.
Correct.
So.
And I'm really glad you mentioned that, because biologically, vitiligo as a disease can just benefit from light.
Right.
So then the question really is, is it a combination? Was the vitiligo going to get better anyway with a little bit of light? Then you added the JAK, which helps, so it's a synergistic effect. Is it the light activating the JAK? In my opinion, it's more a synergistic effect.
I think so.
And I think your paper really highlighted that, and I know you and I on Podium have talked about that. Some of our vitiligo colleagues, as you know, debate on that.
Yep.
And that's the beauty of our
fun.
vitiligo cohort. It's actually fun.
I wish they were here.
Actually, it is. You and I tend to align quite a bit, which is beautiful. But I also love kind of having that controversy with some of our colleagues.
Right.
I think the message is, if you don't have access to UV light in your practice or your community, that doesn't mean you withhold a topical JAK therapy.
Right. No, I have patients who come to see me from all over. Sometimes I forget that they're not from around here. So I talk about, okay, we're in the middle of the winter right now, and they're like, no, I'm from the Cayman Islands. So like, oh yeah, right, you're from the Cayman Islands. You've got plenty of sun all the time.
Right.
Sometimes we can't get them a light box where they are. In the Caribbean islands, it's too hard to get that, but they don't maybe need it. So then we talk about how to use sunlight. And so, again, there's the toolkit, there are the individual needs. We kind of match those tools to the patient. It takes time, it takes a conversation, and that can slow you down a little bit, but man, it is so beneficial for the patient. And it's fun for you too, like once you start to work through that. And
I think maybe one of the things we can kind of end on is the fact that you have dedicated your career to vitiligo. This is why I became a dermatologist, from my own family's experience with vitiligo, as you know.
Yeah.
And I think the beauty of talking about vitiligo in 2025 is that there is an incredible amount of hope on the horizon for these patients that 5 years ago, we did not have.
Right.
10 years ago, we definitely didn't have.
Right.
When I started getting interested, there was nothing we were doing. We were doing steroid shots and light treatments, and then, I grew up with a family that did PUVA and went to tanning bed, I'm talking tanning salon, where you couldn't have access to a UV box. So my younger brother took Sorlin and went to a tanning center.
Wow.
So we are now so much farther advanced from where we were. And so what I encourage anyone watching our discussion today is, get excited about giving your patient hope. Right. You may not be a vitiligo specialist and really like pigmentary disorders, but you can be someone to cheerlead and give that hope as the dermatologist.
Yeah, I know. I heard from a lot of people it was just a drag when a vitiligo patient walked in, because if a psoriasis patient walked in, they had plenty to do, right? And they would come back 3 weeks later looking great. And that just wasn't happening with vitiligo. So it was very frustrating and trying to explain that. But we don't want it to be a secret that vitiligo is now on that same trajectory. So, if you kind of dial back 20 years ago with psoriasis, we're there, and we've got drugs that work, we've got treatments that work, we've got phase 2, 3 clinical trials that are working, and we've got ideas even beyond that.
Yep.
So it's going to explode in a good way, I think, in the next 5 to 10 years.
I know, I can't wait to see the new oral JAKs that are hopefully soon going to get approved, the injectables, the IL-15 therapies. All of that's on the horizon. So we'll have lots more to talk about the next time we sit down. So
I know, it'll be an hour conversation.
Always good being with you, John.
Yeah, you too.